Thanks for joining us. I'm your host, Raquel Faria. I'm a doctor in internal medicine at the Centro Hospitalar Universitário de Santo António in Porto, Portugal. Today, I'm joined by Professor David Isenberg from the Lupus Academy Steering Committee, who will be providing expert insights from the key research and clinical data presented at the Lupus 2025 meeting in Toronto last May. David, welcome, and thank you so much for joining us today. The Lupus 2025 meeting in Toronto this May showed groundbreaking research and clinical insights in lupus and also lupus nephritis, bringing together several experts in the field, discussed the latest basic science, clinical practice guidelines, and also some clinical trials. Today, we're going to go through some of the highlights, not covering it all. It was almost impossible for the podcasts. First of all, David, what do you think were the highlights of the meeting for you, like in summary?
Well, I want to talk in a strange way about the generality of the ambience, as it were, because for many years going to lupus conferences, it's been a little bit depressing. Because, I've discussed this in the past, one of the bitter ironies of my working week is that on a Friday afternoon, I do a general clinic. It has patients with rheumatoid arthritis, psoriatic arthritis, ankylosing spondylitis, and I know that if conventional treatment doesn't work, it doesn't matter because I've got 5 different biologic and small molecule ways to go. That it's almost impossible now to find a patient who won't respond to one or other of those treatments. And yet, the following Monday morning, every Monday morning, I go to my lupus clinic, sat in the same room, and all I can offer these patients is either rituximab or, in very restricted situations, Benlysta. I cannot give them anifrolumab; it's not approved in the UK. And I think this is reflected in the wider community that for years and years and years, we had 30 plus failed clinical trials in lupus. And yet in the last year, or year and a half or so, 3 fantastic things have happened. One amazing week in September last year saw 2 clinical trials, phase 3 clinical trials, meet their endpoints. Obinutuzumab, the fully humanized anti-CD20, and dapilizumab, which blocks the CD40 ligand, both met endpoints in clinical trials. We've had the very intriguing results with CAR T-cell therapy coming out of the group of Erlangen, now being reproduced as this meeting in Toronto confirmed by several other groups. So suddenly the whole thing has changed and people begin to realize this may be a disease which we can find treatments which will move the field forward, which will advance the treatments for our patients, give them a much better outlook. And I think that somehow lifted the whole meeting, actually. For me, that was actually the biggest thing.
Thank you. In the Congress, we started with the year in review, and I do think it was amazing. George Tsokos and Yanis Parodis, they led the year in review, one on the basic science and other on the clinical practice, respectively. David, do you want to highlight something from George's presentation? What were the main issues for you?
Okay, so I think it'd be probably not very practical to go through the very fine detail that George Tsokos went into, but he was looking at elements of genetics, and lupus remains a challenging disease because there are no 1 or 2 genetic elements or particular genes which really are associated with lupus, but rather something like 100, 150 individual genes have been identified or linked to lupus, but in a relatively low relative risk sort of way. So it seems that there is a kind of compound of genetic effect, and I think that was to some extent highlighted by what George Tsokos had to say. Then he went through the contributions of the individual cells, B cells, T cells, etc. Again, highlighting the fact that lupus is not caused by a single problem with a single cell, but rather it's multiple issues linked to multiple cells, and the whole lot gives rise to the condition that we call lupus. But I think it's important to emphasize, as I often do in these situations, that lupus is clearly, in my view anyway, not a single simple disease entity. It's not like a virus causing measles, which is going to cause pretty much the same kind of issues for any individual victim, but rather we get this panoply of clinical experiences, clinical diversity that we see, where some patients who meet the criteria for lupus only have skin and joint disease, others only have renal disease, others mainly have renal and CNS, others have joint disease and respiratory disease. So there are, it's like climbing Mount Everest, but from different paths. We get to the clinical classification criteria, and we might want to touch on those as they've changed recently. But the fact is that there are lupus patients presents different faces, literally in some cases, because almost because the contribution of the individual cells within that individual clearly do vary from one individual to another.
Thank you. And Ioannis did the clinical practice year review. Do you want to highlight some?
Yes, again, I thought an excellent overview talk, highlighting a number of areas of interest, obviously focusing to some extent on these clinical trials that have been successful. In particular, the guidance documents which have been issued by the ACR, by the Renal Association and EULAR are now highlighting, as we probably want to discuss a little bit more, the fact that triple therapy, combinations of treatment now seem to be the way to go forward in lupus nephritis. And this makes use of the fact that we now have other drugs available. So Benlysta has been shown to meet its endpoints in clinical trials for lupus nephritis, so that's coming into the fall. Voclosporin is approved. It's incredibly expensive. In the United States, about $92,000 per patient per year. But voclosporin does seem to be used. Some people prefer it to tacrolimus, so certainly now in our institution, we tend to go for tacrolimus first because it's so much cheaper. But certainly we now have a chance to try out different kinds of combinations of therapy for the treatment of lupus nephritis and to treat it faster and more aggressively. Because I think what everybody agrees, especially with lupus nephritis, is you cannot wait until damage has occurred. As various colleagues have said, time is kidney. And if you allow the kidney to become damaged, then that's not a good thing, because damage implies permanent change and the kidneys are not going to get better.
So moving to the actual presentation and the roundtable, where there was a lot of discussion on the new guidelines for lupus nephritis. And actually on the last 2 years, 3 guidelines were published for lupus nephritis. The first one was the EULAR, then the ACR was published more recently, and the KDIGO guidelines also were published last year. So they are based exactly on the same studies and trials, but they differ a little bit. What do you think, besides what you already said about multiple therapy, what do you think are the main differences, and how can they be applied in practice, even in different countries?
Well, I think one of the elements here that we lack really, and I think it applies to all these criteria, is the element of time. We do not know for sure whether a combination which might consist of steroids plus a tacrolimus plus Benlysta is actually, over a longer period of time, 3 to 5 years, whatever, going to be better than a combination of, say, steroids plus a B-cell depleting agent plus tacrolimus. We really don't know. There are relatively small differences in terms of which particular groups of drugs to go for first, at what point you might want to change things, bring things in. Slightly different numbers are applied as to when patients are considered to be fully responsive for renal disease and so renal activity and so forth. So for me, I think it's important to remember these are guidelines, that they're not mandatory. They're ways in which you can try to treat your patients. And clearly some patients will turn out to be allergic to Benlysta or whatever. So it's nice to know that people, serious thinkers about this topic, have come up with several slightly different ideas as to particular groups of combinations of drugs. And they say you should use this one first, whereas others say you should use another one first. But really, nobody's ever done a comparative trial comparing one group of drugs against another group of drugs. It's really very much as much evidence-based, it seems to me, as evidence-based when you're comparing groups of drugs versus another group of drugs. The data just isn't there. So I think we have to read these guidelines documents with a certain degree of trepidation, because we don't know for sure, as in the long term, which is going to turn out to be the best.
And do you have any thoughts on the debate of voclosporin use versus another cyanide use, and all the issues on continuing therapy with CNI? What do you think were the main messages from that
So
debate?
I think some people clearly are voclosporin fans, I would say.
Yes.
We've been using it in our group for the last year or so, and I'm struck by the fact that our renal physicians, who were initially very keen on it, seem now to be somewhat less keen on it. And I don't think it's just the financial issues, but they say that in many cases, tacrolimus, which it does the same job really, but is considerably cheaper, is the one to use to start with.
Mhm.
And that's what we've been doing actually. So in fact, in some ways, I suppose my personal use of voclosporin it remains very limited. It's been okay in terms of controlling blood pressure in particular, and thus reducing proteinuria. I wouldn't call it sensational, but it may be that these things do work better in conjunction. So we're not going to give voclosporin on its own, clearly, but clearly a combination of voclosporin plus minus Benlysta plus minus steroids plus minus B-cell depletion. The lists are now, I won't say endless, but we do have genuine choices now, and I think that's good. And I think, as they say, it will come out in the wash over the next few years which really is the best combination. At the moment, I don't think we can say with any degree of certainty.
Thank you. There was another presentation versus debate and discussion on Eric's Morand development of Eric's Morand team, development of the novel treatment response measure for systemic lupus erythematosus, which would be TRM SLE, the
Right.
short term.
Yeah.
And what are your thoughts on this development? What are the main advantages versus CRI4 BICLA?
Okay, so Eric Moran makes the point, and I think it's a fair point, that the disease activity indices that we principally use today, namely the SLEDAI and the BILAG, were not created with the idea of clinical trials in mind. And as one of the founding fathers of the BILAG, I can confirm that that's certainly the case, mainly because when we put these indices together 30 to 40 years ago, there were so few drugs available to treat lupus patients, the chances of doing clinical trials seemed rather remote. We just wanted to capture disease activity better. But without going into the long-standing arguments, which is better, SLEDAI or BILAG, what I would say is that, very briefly, the global score systems give you simplicity and they're faster, but they don't give you the depth of capturing all of the disease elements, and in particular, they don't distinguish between the patients who are somewhat better from the ones who are the same, or even the ones who are worse. And BILAG does that. But as Eric will point out, that's fine, but that doesn't mean that they're going to be particularly effective in clinical trial situations. So he's trying to come up with his colleagues with a kind of index which is directly aimed at capturing variation in the rather special situation in which clinical trials offer. Because when we do a clinical trial, we cherry pick the patients. They have to fit the bill. They have to have a certain level of disease activity. They can't be less active, they can't be more active. This is particularly true actually in CAR T cell therapy, which we might come on to, where it's clearly what I call a Goldilocks situation. You can't be too ill, you can't be too well, you've got to be right in the middle. You've got to agree to have a kidney biopsy. You've got to agree to go through what's quite a long process. So Eric is trying to come up with a way of capturing disease activity and improvement within the context of clinical trials. Now, how successful that is going to be is, I think, a very moot point at the moment, and whether or not, as they say, the candle will be worth the light is unclear. So BICLA and SRI4 have been around for about 10 years now. The advantage they offer is that we now can compare them in a whole series of clinical trials, and we can see the classic example is the TULIP trials, which are the trials of anifrolumab, where TULIP 1 started off with the SRI4 as its primary endpoint, which was not met, and yet BICLA, which was a secondary endpoint, was met. And so what they then did was to switch them around so that for TULIP 2, BICLA became the primary endpoint and SRI4 became the secondary endpoint. in those circumstances of tulip 2, both activity indices were met. So I think Eric would sort of use that to say, well, this shows you the challenges that you face when you're using combinations of disease activity indices which were not designed with clinical trials in mind. Whereas what we're doing now is to try to overcome that and say we're going to look in great detail at how we can use a system which is slightly better for capturing disease activity and reflecting what's going on in the context of the trial. So interesting work. We'll have to see how it works in reality.
Yes.
He, of course, and his colleagues have introduced the LL-DAS, which is, I think, which has found a lot of favor, although it does use the SLEDAI system.
Okay.
The problem with that, of course, is that the SLEDAI system doesn't allow for gastrointestinal disease, doesn't allow for hemolytic anemia, doesn't allow for ophthalmic disease, so it misses out quite a few things.
Yeah.
And the argument that Eric and colleagues say is, well, actually, to cover that, we use the Physicians Global. My counter argument is to say, well, if you're so impressed with the Physicians Global in those circumstances, why don't you just use the Physicians Global for everything? I haven't had an answer to that one yet.
So for clinical trials also, and talking about indexes, Ian Bruce presented some of the preliminary results of the new damage index. And what is your opinion? You are in the group, so what is your opinion on the use of the new damage index versus the previous one, mainly on clinical trials?
Okay, so again, I think a little history here is useful. The original damage index was put together by the SLIT group and published in 1996, so it's been around for 30 years.
Yeah.
In one sense, you could say it stood the test of time. It was always aimed at trying to keep things as simple as possible, and it was never an attempt to identify the cause of the damage for a very pragmatic reason, which is that sometimes it's extremely difficult to do that. So as an example, if you've got a cataract in a patient, is that cataract due to the fact that a particular patient has a mother who's got a cataract? In other words, it could be a genetic thing. Is it because the patient also happens to have diabetes? Is it because the patient happens to have been on a lot of steroids? So it's not an attempt to identify the individual cause of the damage item, merely to capture it. And it's worthwhile saying that it is important to capture. And I think the best reason for saying that is because there was a phenomenal paper published by the Toronto group some 20 years ago now by Rahman and colleagues, not my colleague Alistair Rahman, but Proton Rahman, who interestingly has a sister called Electron Rahman. They were the children of a nuclear physicist, so that kind of makes sense, I suppose. What Proton Rahman did was brilliant, I thought. He took about 270 odd patients, I think, on whom he had a damage index 1 year after the onset of the disease. And he divided them up into those patients who had one item of damage or more, or no items of damage. And then he followed them up for the following 9 years. So it was a 10-year follow-up study. And what he showed was, and it is quite remarkable, if you have a single item of damage, whatever it is, doesn't really matter, your chances of being dead 9 years later are increased by 3 times. And that's kind of worrying. So the idea is that you've got this link between activity causing damage, damage causing or predisposing to death. Now, the new damage index attempts to sort of capture some holes in the system, partly because the imaging, which was not widely available, like CT scanning, MRI scanning 30 years ago, is now widely available. So, for example, if you're going to look at avascular necrosis, although obviously it's true you can capture it with an X-ray, but you can capture it rather better with CT or MRI scanning. So, in other words, it wanted to make use of advance in technology and to say that actually we can't ignore it completely, although it is true that obviously with some countries that the advanced technologies are not always so readily available. Wanted to capture that. It also wanted to look again at some individual items to see if we still agreed what actually constitutes damage items in individual systems and organs. So it's been a very long process, and I'm sure Ian would confirm that if he was on this call. It's gone on for several years as we've sought the advice of people outside of the group. I mean, literally dozens and dozens of people outside of the group have been incorporated into this big effort to look in great detail at what really constitutes damage. The other issue that we have sometimes faced is, what do you do with a patient who might have had a damage item before they got their lupus or just before they got lupus? Should that be counted? Should it not be counted? We haven't really looked at another aspect with respect to children. So here's an important question. One aspect of the current damage index relates to a GFR. And if that drops below to 50% of normal for more than 6 months, it was generally agreed that in an adult, it would never increase back to more than 50%. But that's not true with children. With childhood onset lupus nephritis, it clearly is possible to have a very low GFR, which does improve, perhaps not necessarily back to normal, but certainly much better. And that wasn't ever captured in the original damage index. So for these kinds of reasons, we felt 6, 7 years ago now it was important to look at it again. And we're getting fairly close now to putting it all together, though it's going to be, once we've got the damage index agreed, it's then going to be tried out within the context of a couple of cohorts to see if it really seems to work and what differences the new damage index will compare to the old damage index. So although it's very much work in progress, I don't think I don't see a publication round the corner just yet.
Okay.
Could be another 2 or 3 years.
So, but what we discussed in this session was that with the previous damage index, if you had 2 points of damage, you would go never again to 1. And with this new, it is possible to lower at least a little bit with time the damage index. And it's really a new concept. What do you think of this new concept for clinical trials?
Okay, so I have to confess that I am of the school that damage is permanent, and this is not a sort of an aspect of the index which I personally favour, because I think it is important to distinguish something which can be correctable and deem that to be activity because you can get it better, from something which is permanent and is never going to get better unless you've got some major change. So for example, if you've got avascular necrosis of your hip, yes, that can be improved if you put in a new hip. So you could say, well, then the damage has, in quotes, got better, but it's sort of taken it to another kind of level, which I don't think was the original intention of the damage index. So for me, I remain a little bit uncertain about that element.
Okay, let's move to another topic. There was a presentation from James Salmond on the results of the IMPACT trial on the use of sertolizumab to prevent pregnancy complications in APS, so antiphospholipid syndrome. We already were expecting these results, and they were published in April. So what do you think of the use and the results? They are still a little bit preliminary of all of that, but it looks that it impacted the outcome of the pregnancies. So what are your thoughts and the beneficial use of anti-TNF in pregnancy?
So it's probably worthwhile saying that the last big advance in this area, because the problem with studying APS is that the clinical events are hard to call, especially or perhaps even more on the clotting side than on the recurrent miscarriage side. But the last big step forward came from a paper done by a lady called Leslie Regan, who's an obstetrician and gynecologist in London, actually working with a colleague of mine, Hannah Cohen, when they published data suggesting that a combination of heparin and aspirin given to patients with APS would help to get a lot more patients through pregnancy and produce a lot more live births. And that was a big success. But I think it's also true to say that it's not universally successful. And although it's true that many more live births have been achieved that way, a number of the babies are still being born rather prematurely. So this was a magnificent lecture, I thought, by Jane. I think she kind of, and I had a chance to talk to her about this after. She said, really, my whole scientific life was in this talk, because she said, I started out looking at APS from the point of view of an animal model, trying to get an idea of the mechanisms behind it. Then we moved to study clinical patients as an observational thing. Then we moved to the idea that TNF-alpha might be important. And then the notion kind of occurred to us, well, if that's true, then maybe we could block it to some benefit. But to set this trial up, as she explained in her lecture, was very time-consuming, very hard.
Yeah.
And she managed to do it. She got the funding together for it, and she's been doing this for several years now, and it looks remarkably good. I think from memory, she talked about 45 out of 47 pregnancies getting to the end of the pregnancy very successfully using sertolizumab, which is again a big advance. So that was again a very exciting lesson to hear. But what I loved about it was the fact that it sort of went from the basic science of it, approaching very method very very carefully, try to work out the individual factors which were likely to be responsible for the problems, identifying what they were, and then saying, well, actually, we can treat that with a drug which is available. Let's use that in the clinical trial, and showing that the clinical trial actually does work. Fantastic stuff.
Yes. And we also discussed a little bit if it was going to be only for satralizumab, or if it was also okay for other anti-TNF antibodies. Actually, the price is really different between satralizumab and adalimumab, and currently adalimumab is said to be safe in patients with other diseases that were already doing it. So what do you think is coming on the clinical practice? Do you think that people will use satralizumab, or do you think that people will use adalimumab?
So that's a very interesting, good question. I think personally, people will start off using the one which has been clearly shown to work, satralizumab. But I think where price is a factor, and obviously in certain countries and certain institutions it may well be, then I think people will say, well, actually, why don't we use the slightly cheaper option, which has been shown to be safe? Why don't we use adalimumab? And I think that's going to happen as well. So I suspect there will be a bit of a split in due course. And again, it would be interesting. I suspect it'll never happen. A direct comparison between the two, but that will be an incredible trial to have to set up. So I think we'll see certainly the use of satralizumab continuing, but I think gradually people will try to use other options to see if they are as good, and obviously they may well be cheaper.
And how do you feel about using an anti-TNF in a pregnancy of a person that, besides having antiphospholipid antibody, can also have lupus? The trial, there were patients with lupus also. So how do you feel about it?
Okay, so for a number of years, I chaired the British Society of Rheumatology's Biologics Register, where we were comparing 4,000 patients each on drugs like infliximab and Enbrel and adalimumab with 4,000 active rheumatoid patients not on a biologic drug. And one of the things that we noted was that although patients were not supposed to get pregnant on these drugs, and of course, as they say, stuff happens, and many of them did. And we were able to show, and this work has been published by many other groups now, that actually the TNF-alpha drugs have a pretty good safety record in pregnancy. So I suspect that the reality is that these drugs can be used in pregnancy and will be used in pregnancy, especially where you've got mothers who are desperate to have kids. If they've lost 2, 3, 4 miscarriages, whatever, they would try almost anything to try to get pregnant and to sustain it through the pregnancy. So I think that is going to happen, and I think in effect it has already happened.
And how do you feel of giving an anti-TNF to a lupus patient?
Okay, so I've actually reviewed this in a couple of papers. One of the things that we looked at in the Biologics Register was at the numbers of patients with rheumatoid or psoriatic arthritis given TNF-alpha drugs who develop lupus. And the number was incredibly small. I mean, it's tiny, tiny. I mean, a handful, certainly under a dozen, I think it was, out of several thousand patients. So for me, giving a TNF-alpha drug to a lupus patient in this particular circumstances for a finite period of time, I don't think is going to concern me too much, especially if the patient happens to have quite inflammatory arthritis, because, as you know, there's about 4 or 5% of patients who we sometimes refer to as lupus because they've got a bit of rheumatoid and a bit of lupus. So for those in particular, it wouldn't be a problem. So I don't have a particular problem with it.
Thank you. There were so many other presentations that we could discuss, but I can't really help I love neuropsychiatric involvement and I'm really into it. And I also enjoyed a lot of the Congress because there was a lot of presentations on NPSLE. So between all the NPSLE presentations, neuropsychiatric, what were the ones that caught most your attention?
Okay, so the one which I particularly enjoyed because I thought it was very well done was Chaim Passerman did a very, very nice, I think almost an hour-long presentation, a big review of the whole field. And the issues around CNS lupus, the key issues for me are the fact that it's so challenging to work out the immunopathology in the individual case.
Yes.
We know that there are different potential mechanisms. We know that antiphospholipid antibodies can cause problems. We know that there are some antibodies which bind to structures directly in the brain once you've penetrated the blood-brain barrier. We know from post-mortem studies that vasculitis can be an issue. But of course, what we can't do in CNS lupus is to do a brain biopsy with the alacrity with which we can do a skin biopsy or a kidney biopsy. And in my career, I think I've actually requested 3 brain biopsies. What I would say, I don't think it's just me, is that every time before we did it, my colleagues discussed what we thought the biopsy would show, and in every case we got it wrong. Each of those 3 cases, we got it completely wrong. So I think that sort of highlights the point that CNS lupus is tricky because we so rarely get tissue, which is really what you need to give you the ultimate diagnosis. It's particularly hard, I think, because if you do MRI scanning, it is true that multiple small thrombi can look rather like multiple small vasculitic lesions. It can be quite difficult. Even the neuroradiologists that I deal with here at National Hospital of Nerve Diseases, Queen Square, say, yeah, it's difficult to be sure. So clearly the treatment for cerebral vasculitis is going to be rather different from the treatment of a patient in whom you suspect multiple small thrombi. And very often, or perhaps exaggeration, but certainly from time to time, I've ended up covering both bases. So where you've got a patient with, let's say, lowish titer antiphospholipid antibodies, but it's clearly got lupus, they then get some form of cerebral disease. I've often ended up giving them either a VKA together with steroids and cyclophosphamide just to cover all the bases, as it were. So that's a problem. And of course, the other thing which I know has driven you as much nuts as it drives me is that virtually every single trial of lupus excludes CNS lupus,
Yes.
excludes it, so that we have so little information coming out of clinical trials where we can say, well, based on clinical trial X or Y or Z, it's very clear that drug A or B or C is better. We can't say that. We have scraps to feed on. We really do. And there are in the literature a small number of case studies with patients with seizures or with psychosis have been given drugs, given biologic drugs, but there's so little data, really hard data. It's very hard, and even someone as good as Chaim Parderman and others in this field really do struggle to sort of recommend what's the best treatment for X or Y because there's just so little data.
Yes, I really enjoyed the Pokemon presentation and going through all the basic science talk, but I was amazed with big trial that has been done in cognitive dysfunction and the biomarkers of MMP9 and calprotectin. And I think this, if the memory doesn't fail me, there were 290 patients that had the MRI and the biomarkers, and it really looks like that calprotectin is a good biomarker to predict cognitive impairment. And actually it is continuous inflammation that we are not capturing by other biomarkers and clinical. So I really thought it's a landmark, so we can work further after that. And I also enjoyed so much the radiology presentation with the new functional and tactography MRI. It is all only research by now, but there are new index that is being created to make the findings more reproducible across the world. So it gave us some help and the hope for us to be more present on the NPSLE in the future.
Well, I agree, and it is. I couldn't agree with you more that with the capacity for scanning, the results that you can get from them are phenomenal. We're going to announce in London in the next 2 or 3 months the results of a trial which we've done mainly. Well, these are patients with APS, but lupus patients could also come into the trial. These are patients with a history of arterial thrombosis, and we made a comparison of patients on high-intensity VK, particularly warfarin, 3 to 4 versus rivaroxaban at a higher than normal dose of 30. So we have about 21 patients in each arm of the study, and the endpoint, the primary endpoint, is CNS imaging. Now, this has been conducted on a very sophisticated scanner down at the National Hospital for Nervous Diseases, where they're able to count the number of white matter hyperintensives and capture the volume of them as well. So we're making a comparison between. We've completed the study now. We've just done it. We're going to have a results meeting next Wednesday. So I'm quite looking forward to that, actually. So it's going to be interesting to see what we find, but that data should be out quite soon. I should say we restricted the patients to the ones who had just one or two phospholipids, not the triple positive ones, because of the concerns that have been raised in a number of clinical trials. But it would be very interesting, clearly, if high intensity rivaroxaban turns out to be as good as warfarin, or at least no worse, not least because obviously taking rivaroxaban is so much easier than taking warfarin with its restrictions in drugs that you can take with it or foods that you can eat with it. So that trial should be out a little bit later this year. But yes, CNS imaging advances are phenomenal, absolutely phenomenal.
And another presentation that kept my attention was from the Duke's University, that they presented their work between distinguishing type 1 and type 2 symptoms in lupus patients. And they actually came up with a physician global assessment only for type 2 and trying to compare the physician global assessment for type 1 and type 2 and trying to move then the workup for the patients based on this. And I thought it was amazing. And it has to go with a little further research, but I thought it was an amazing model to work with the patients, trying to objectify, so trying to make it measurable also the physician's notion of the type 2 symptoms. I thought it was really amazing.
Yeah, I heard about it, and though I didn't see it, but as you say, it does sound fascinating, and I will make a point of trying to read about it a bit more.
So, finally, David, the debate between which biologics should we use in lupus? Rituximab, belimumab, anifrolumab, obinutuzumab, and all the mAbs that are coming, and IBs that are coming. And you were involved in this debate with Advital. So when to use this? Which are the main features of patients that should benefit most from one or another?
So the background to this for me was a fantastic talk given by Sandra Navarro at the last Lupus Academy, where she made a point of saying that where you live in the world is very important in terms of what drugs, what monoclonals in particular, are available to you. And she highlighted the fact that if you live, for example, in America, you can get hold of Benlysta, no problem, anifrolumab, no problem, voclosporin, no problem. But because it didn't meet its endpoints in its original clinical trials, rituximab is hard to get hold of. And I'm told the same is true in Germany. In the UK, as I've hinted at from the start of our discussion this morning, we can get rituximab, not a problem, absolutely no problem. We can get hold of Benlysta in rather restricted circumstances. We cannot use anifrolumab because it's not been approved by NICE. In the Philippines, where Sandra works, the only drug that she can use are rituximab biosimilars because they're relatively cheap.
Mm-hmm.
So I think we have to sort of remember that part of the debate has to be couched in the terms of what's available in different countries. Now, let's imagine, though, that you were, as you say, in a perfect situation. You can choose whatever drug you like. What would you use? So I think people would agree that anifrolumab is particularly good for skin rashes. And I remember being very much struck by some brilliant work that was done by Ed Vitale, published in EULAR about 3 years ago now, actually, in which he'd taken 8 patients who'd failed everything, very aggressive rashes, nasty rashes. They'd failed rituximab, they'd failed Benlysta, they'd done nothing with steroids, they'd done nothing with MMF, but they were put onto anifrolumab, and within a month, you could see incredible changes. So this is a really good drug, it seems to me, for patients with hard-to-treat dermatological conditions. I think that Benlysta, most people would say, works slowly. and that's a problem. I find it very difficult to say to patients who've got very bad arthritis or very bad rashes, look, we're going to try and build a list. And the good news is, in 3 or 4 months' time, you're going to be feeling better. They say, "I want to feel better tomorrow. Give me steroids. Give me steroids." And that is a challenge. It's very safe, though. My gut feeling is it works pretty well for about a third of the patients that I treat. We've probably treated now about 30 in my group. About a third, you can say there's some benefit, but for a third, there's no benefit. That's been my experience. Rituximab, obviously, I have some particular interest here, as I was the first person to use it about 25 years ago. And we've used it in a variety of circumstances. What's intriguing to me about the use of B-cell depletion in this discussion is the fact that it seems to work at a differential rate, and I highlighted this in the discussion. It works very effectively for low platelets and for anemia. Within a week or two, you can see substantial improvements. It's really quite striking. With arthritis and skin rashes, where it works, it's often 1 to 2 months. With renal disease, it's more likely 2 to 3 months. So you have to be more patient. But of course, the problem with rituximab, as you're aware, is that it's about 20% still in its mouse format. So about a fifth or sixth of the patients that I give rituximab to, it might be effective, but you can't continue to give it to them because they've had an allergic reaction to it. So for those patients, obinutuzumab, which is fully humanized, should be much better. And the work of my colleague Venkat Reddy showed that it's also more effective as a better depleter of B cells.
Mm-hmm.
Though, of course, if you want to go for complete B-cell depletion, then CAR T cells seem to be your best bet. I had the opportunity to interview George Shett at the ACR meeting the year before last, and he said to me, really, he said, I think of CAR T cells as a very expensive form of B-cell depletion because CAR T cells get into the tissues in a way that rituximab and obinutuzumab will not do very effectively. So I think for him, it works because it's more efficient at getting rid of B cells. So the discussion I thought was very it was very lively. I think everybody has slightly different views. One issue which is not often discussed but probably ought to be is at what point should you introduce biologic drugs? Should you wait until failed, which is the conventional way to do it, or to try what Liz Lightstone did in London many years ago now and said, well, actually, if it's going to work at the end of the lupus journey, why not use it at the beginning of the lupus journey with the view of trying to prevent the use of steroids, which the work from Toronto has shown it's steroids which contribute at least a third of the damage in lupus patients. So Liz unfortunately tried to do a trial which would have proven that, but that unfortunately found it hard to recruit the patients, and unfortunately the company who was supplying the drug withdrew it in the middle of the trial, which was a bit of a blow. So we may never find out about that. But I don't think we should forget the possibility in the future that using B-cell depletion, or indeed other forms of biologic therapy, early might be better than waiting till conventional drugs have failed.
So, David, what do you think that endocrines is worth any comments, additional comments? Additional thoughts? What are other presentations? And I'm not going to ask you straightforward for the CAR T cells, but if you want to, you can discuss it.
So I think for me, because my interest to turn increasingly towards therapies is the notion that, just to get back to my story from before, that in a year or two's time, we might be in the same position that we are with our RA and psoriatic patients. Say, look, we have an array. We could give you B-cell depletion either with biosimilar rituximab, or we can give it to you with obinutuzumab. We can give you, if you're particularly sick, we can consider CAR T-cell therapy for you. If you've got a bad rash, we'll give you anifrolumab. It may be that the other drugs, which things like deucravacitinib, ianalumab, other drugs which block either BAFF receptors, tabalumab, which blocks 2 B-cell receptors, APRIL and BLyS, may also have a part to play in this. What I would very much like to see is, as I say, in 2-3 years' time, I'll say to my patients, here's our array of options, and we're going to decide for you. We're going to try to personalize this. Why do I think that drug X is better for you than drug Y? If you've got a very bad skin rash, I might well say, I think anifrolumab is the one for you. If you've got hemolytic anemia, I'll say, well, actually B-cell depletion will be very good for you. We've also got the exciting prospect of these bi- and tri-specific monoclonals which combine to, say, CD19 on a B-cell and a T-cell receptor at the same time, and that may be very interesting. And the several companies are working on those. So for me, I feel that sort of dangling in front of us is the prospect of much better treatment, because we shouldn't forget, although you obviously won't forget that lupus continues to do terrible things to people. The standard mortality rates in lupus remain far too high. And we, for example, very sadly lost a lupus patient ostensibly following an aortic valve replacement, but he'd had his disease for about 17 years. About 4 years ago, so 13 years into his disease, he suddenly gets catastrophic renal disease, and then he gets aortic incompetence. Then he has an operation which got complicated afterwards, very bad pericarditis, and he died at 35. And you think, oh, this is really bad disease still. We still haven't got it sorted. So I think that for me is what wakes me up each day and keeps me going each day. The thought that, in a finite number of years, I think we will see some phenomenal changes. And I'm reminded, if I may give you a personal anecdote and analogy, when I was a very young doctor, I spent some time at Queen Square on a ward which was treating patients with multiple sclerosis, where the choices of treatment were more or less steroids or more steroids or a bit of azathioprine, and that was pretty much it. But I have a nephew who sadly has developed multiple sclerosis, and he called me up after his diagnosis, and he said he'd been to a well-known hospital in London. He said they told me there are 14 different drugs they treat my disease, and you think, wow, that's astonishing. Just in one lifetime to sort of go from steroids and more steroids to 14 different monoclonal antibodies. And I hope very much the situation will pertain to lupus, that 20 years ago, there was rituximab available in a few places, and perhaps in 4 or 5 years' time, there'll be 5 or 6 or 7 different drugs proven to work. And the decision that we will make is which one of those 7 proven to work approaches is going to be one we're going to use for that particular patient. That's exciting. That's what keeps me going.
Thank you so much, David, for joining me today and sharing your insights. To our listeners, we hope these discussions from Lupus 25 have helped you gain more of an understanding of lupus. Thank you so much for listening. We hope you enjoyed this podcast. Please leave us a review, which will really help us in reaching as many of your colleagues as possible around the world.